For you, all of you that don't know me, I think everybody does. Dr. Elmlinger here, and thank you for the shorter podium so I can actually see over this. I appreciate that. So I haven't worked this before, so give me a second to kind of figure out what this does. All right, no financial disclosures. We've already done that. So this is going to be very basic talk. I want you all to understand that the different types of fractures, the mechanisms. If you see them in the primary care arena, it's going to be fairly simple, but if you guys rotate through the ER, you have to be ready to actually look at the patients, touch the patients, look at the x-rays. And if you call me or Dr. Lessenberry and you don't have information about the patient, and I can tell you have not touched them, oof, okay? All right, so goal of the talk, no more than you did when you walked in, which won't be hard for a couple of you. All right, so the biggest thing with fractures, we know it's a break in the continuity of the bone. We know that the skin can be intact, or it can actually go through the skin, which we consider an open fracture. The old terminology was a compound fracture, and you'll still hear that around when the bone's sticking out of the skin. Anymore, of course, these are two examples. Is it a fracture or a break? So, is this a fracture or a break? Anybody? Yep, spit it out. It's okay. You're not going to be wrong either way. Okay, what's that one then? Right there. Okay, what if I told you they're both fractures? Would you believe me? Right, because we got rid of the terminology break a long time ago. So we have non-displaced fractures, minimally displaced fractures, jacked up fractures. That's not a real term, but yeah. Well, when we talk, it is. But the thing about it is, again, when somebody comes to your clinic, they're going to say, I broke something, which is not wrong. But when you use your terminology to tell me something, or to talk among colleagues, or put in your notes, you say fracture. Then you say, what kind of fracture, which we're going to come to. Okay, so scientific term we know is fracture. The layman term is going to be a broken bone. All right, again, when you get down to closed versus open, a lot of times open was called compound in the old days, but it isn't anymore. It's just called open fracture. There's different types. We won't get into that. Closed fractures are most of the fractures we deal with in our ER. If you ever see something otherwise, typically, I'll get to the picture here. So if this ever comes in, we're not going to be dealing with it. Okay, is that a closed or open fracture? That's a way open fracture, right? All right, so we're not usually going to deal with that. If it comes to our place, it's not going to be a sporting event, unlikely. It would be an MVC or somebody fell off a roof or something like that. If they have that sort of injury, they probably have other injuries, and we usually ship it out to a trauma center. But that is an open one. How about this one, open or closed? Speak louder, or forever hold your peace. Good. Good answer. All right, so all we see is blood here. We don't know where that came from, right? So it could be either one open or closed, but we see a lot of these that just barely have a little bit of blood. You got to check the x-ray versus the deformity. So sometimes somebody will have an x-ray and the fracture will be over here, the opening will be over here, and is that an open fracture? No. So make sure you check that. Don't just call something open just because there's an opening somewhere. All right. Any questions about that? All right. Then you have this. This is not good. I used to see these in Jacksonville more often than I wanted to. I don't know how often we even see them in the ER here. If we do, I never see them because they're too much. But this was a common thing. So when you have, shot. One good question to you all is, do you have to get all those fragments out? Can you get all those fragments out without stripping everything that's in there? No, not really. So most of the time you just try to clean up around the fracture and you're pretty well out of there, and you just hope that they don't get infected. But if they have a gunshot like this, you're kind of in trouble. All right, so there's a lot of different types of fractures that you can get. There's different mechanisms for everyone. Of course, normal bone on this side going all the way over to your children's torus or buccal fracture, and then green stick fractures we see. It doesn't have the physeal fractures on there, but the other ones are pretty well covered. The main ones are going to be these. So, quick question: where's bone the weakest? What kind of force do you put on bone, and it's actually the weakest in that force usually? So we got choices here. We have rotation, we have bending, we have compression, we have traction. So what would you say? Who said that?
I'm guessing it's rotation.
Oh man, you can't guess. I know you're right. Okay, that's not even a guess. Okay. Well, okay. Typically, long bones. Let's go long bones. Rotation. Okay. All right. Anyway, different ways that you can break bones, and of course, there's different ways that we're going to fix them. You aren't going to be too much paying attention to that. Now, kid stuff, you better pay attention to. All right. So if a kid comes into ER and they have one of these fracture patterns, first of all, type 1, Salter-Harris type 1. Can somebody describe what that looks like on x-ray? Anybody? Normal. Yeah. So that's a physical exam finding. So if you have a kid that's just like crying and you're pushing right on a physis, their growth plate, you just assume they have it. And that's into that. You splint it, you cast it, whatever you want to do to protect it, and you're going to go on. That doesn't happen often, but in our world it happens a lot. The type 2 is the one that really gets the cake as far as it happens more often than any other fracture of the kid. Type 2, can anybody describe a type 2? I know you guys have to learn this stuff for boards. All right, so you have a physis, right, which is type 1. Then you have a metaphysis that is proximal to the physis. Then distally, there's an epiphysis. So this one is the physis plus one of those other two. Which one do you think it is? The softer of the two, which you may not know that either. But metaphyseal bone is very soft. So this is a metaphyseal fracture into the physis. So type 2, you can see right there kind of going into it. Typically, these are going to be not very displaced. So most of the time you can take care of them in the ER. A couple of the docs down there are really comfortable. I'm looking right at Kaiser because he really is. If it's minimally displaced, he can move it where it needs to be, and he's going to feel probably pretty good about himself. But if you aren't sure about yourself, do not manipulate any kid fracture. Because what are you dealing with that we're worried about? The growth plate. If you jack up that growth plate, which even in these, a small proportion of them can go on to not continue to grow if you mess with it, even after the original injury. So let's say you try 3 times to get that reduced, and I didn't get it. Let's call up the orthopedic person and see if they can get a hold of it. Well, that might be too late. So we have to worry about that. As you go down, I'm going to show you a couple examples of these. So this is your typical type 1. Now what you need to know: epiphysis, physis, metaphysis, diaphysis. So diaphysis is the longest part, the hard cortical bone that we know about. Doesn't heal as well as this does. Metaphysis heals really well because it has good blood supply. But it is also sitting there in its softer bones, and so it usually cracks there. All right, so looking at this one, what type do you think that is? We have 2 views of it. Where's it broken? Which bone's broken? Radius or ulna? Radius. Ulna. Okay, we don't know really with the ulna. You're like, I don't know. Radius you can tell though. And that's a metaphyseal piece off the radius, so this is a type 2. All right. Type 3, we're talking a little bit different mechanism. The ankle is a good place for this to happen because you have twisting and you have bending that's not necessarily at other places. So we're at a joint. So at a joint, you can break through the epiphysis here into the physis, but it's not going any further. So we'll call that a type 3. In this situation here, it looks like the fibula might have something going on too. It's a little bit different colored, hard to say. So what do you think you would do to this? Surgery? Anybody vote for surgery? that'd be stupid, right? You know, why would you do surgery? No, there are certain fractures that, believe it or not, look simple that need surgery. So I don't want to throw you guys off the wrong thing, but typically this would be non-surgical, and we put them in a cast. It's a kid, you know, you're worried they're going to mess around with it, so you put them in a cast. An adult, similar fracture, maybe a boot. All right, this is a bad one. This is a type 4, so we're moving on up. So now we're going through, all the way through the physis, the epiphysis, physis, metaphysis. This is typically what you'd see on an adult. It would go all the way through like that. It's non-displaced, or at least we're going to say it is, so we still can treat this non-operatively. But if it is displaced, we're going to try to do the best we can not to interfere with the physis. So we may end up throwing a screw across the epiphysis. More than likely, that's what's going to happen. And then maybe still cast them if you don't trust the kid, which is most of them. And then the worst is if you crush this. This has the worst end game, the worst thing that could happen. So this is more likely that you're going to end up with a physeal arrest. If you think you have a fracture that's going to do that, if they come to your office, I'll just throw this out. They had a fracture 6 months ago. We already treated it. They never came back. You know, they're doing great. And they're limping, or something doesn't look right. You get an x-ray and you look at it, you're like, well, that looks a little bit weird. Looks like this part doesn't have a plate or a growth plate anymore. This part's solid. That's trouble. That means they have a growth plate arrest, and you need to send them to us as soon as you can, because something's going to have to happen to either stop that from growing further one side or the other side. You have to even it out, which you can if you get them before they're fully matured. And that happens. Anybody ever heard of that before? Growth plate arrest, or had to deal with it? I had a kid that broke both of his wrists, and then a year later came back because his dad said, well, the one doesn't look quite right. And sure enough, one of them was fine and the other one was arresting. And so it was starting to actually rotate in because the radius is what was arresting. So I sent him to pediatrics. We don't really deal with that, but send him up to COSARS. All right. Does anybody know the difference between primary and secondary fracture healing? It's okay if you don't. So if you put a plate on a bone and you're squeezing the bone together, you're relying on the bone to reach to the other side. That's primary bone healing, but it has to be very solid to do that. So plate and screws. Secondary is most everything else. So for instance, this plate and screw set up here, it's probably really hard for you to see where the fracture is. I think it's right about here, and you shouldn't really be able to see it. Because if you want primary bone healing, where there's these little cutting cones and osteoblasts trying to cross, that's the only way it can be. If you have a gap, the gap will remain because it can't heal the other way, which is secondary. Now, secondary is more than what we have here. Does anybody know what kind of fracture that is that we treated? Yeah, intertroch. All right. If I had a pointer, I'd say, all right, that's one of our common ways to treat this. But if you put somebody in a cast and they had a fracture in an area, that's going to heal the same way, secondary. If you put them in a X-fix, same way, secondary. And I had those extra pictures on there, but I didn't get them across. So, all right, factors affecting bone healing. Does anybody think age matters? All right. I used to be told kids can heal anything. It's hard to mess up a kid. You have to work hard to mess up a kid. So, which is good. Now, older folks, it's a much different story. Or somebody that has unusual bone, or where somebody has cancer or something like that, it's much more difficult to figure out how they're going to do. Now, the pattern matters as well. So which one of these patterns, spiral, oblique, transverse, or comminuted, which one do you think would have the hardest time healing? Across the board. So if we went back to that gunshot, what would that be? That would be a comminuted. All right, so comminuted, you've blown it up. So your blood supply on the outside of the bone and on the inside of the bone have been disrupted. So you've run your chances down. Still, you're better off if you're younger than older and all that stuff. What do you think would be the second one, spiral, oblique, or transverse? Who said? I didn't hear it. Oh, Dr. Munch. So what's interesting is you would think a transverse fracture, it's still in line, it looks really good, would heal easier than spiral oblique, but that's not the case because of the surface area of the bone. So if you're not careful, if you have a transverse and you squeeze it really well, it goes pretty well. If you have one with a rod, you put the rod in there and somebody's kind of pushing down on it, it goes pretty well. But the reality is spiral and oblique fractures have more surface area. So they tend to have more of an ability to heal across that surface area. Then of course, you always have to worry about soft tissue getting in the way of things. And I had one of those just today, as a matter of fact. I had a 100% displaced fourth metacarpal fracture, midshaft, off in both planes. There's almost no way something's not in between there. So if you try to throw a pin down something that there's something in the way, you're not going to get good healing if you have pieces of soft tissue in the way. So, all right, so this is just basically going through one of the things that bugs us is we're making this hematoma as orthopedists, and we're thinking about all this stuff. There's blood supply on the outside and the inside, right? So we don't want to disturb both of them if we can help it. So we're either going to do rod, which is inside, keeps the outside blood supply, or we're not going to do anything. We're going to put them in a cast, and that keeps the hematoma, the outside blood supply, just in case the inside's comminuted. Or we can put a plate on it and squeeze it together and not do anything to the inner portion of the bone. So any way we look at it, we try not to do something to the whole bone if we can help it, because the chances of it healing are much worse. So one of the things we got to make sure that happens is we need these precursor cells to come in. What do you think brings that on? Inflammation. So why do you think we get a little bit leery when somebody comes from the ER and they've had a shot of Toradol and then they've given a prescription of Toradol in a fracture? And of course, with our population, they smoke, they're diabetic, they're overweight. So we're just adding fuel to the fire if you add an anti-inflammatory on them. So it may not heal as well. Kids, again, doesn't matter. They'll heal no matter what. So I wouldn't even think twice about giving them an anti-inflammatory. So again, the other thing, how long does it take for a fracture to heal? Anybody? 6 weeks. Who said 6 weeks? So what happens after 6 weeks? Typically, why did you say 6 weeks? Well, it's okay, because that's when we take the cast off, right? Everybody knows at 6 weeks, hey, that's when the cast comes off, but that's not really when the bone's healed. It takes about 12 weeks. So you still have to be very careful. That's why we wear braces or splints. We try to get weight bearing on this because it improves the bone growing. But it actually takes a year for this to remodel, which is the interesting thing. So you could x-ray somebody with a fairly bad fracture at about 2 weeks, and then at a year, all of a sudden you're like, dang, you can still see the fracture, where it was. All right, so this is kind of an example of that course. You look at that. Which type of healing is this, primary or secondary? Secondary, right. So somebody probably put this in a boot or cast or something. It's not shown, but it's secondary because there's no hardware on it, right? Nobody squished this together. So that's how bone normally heals. All right. Now, we've all seen these people come into the office, right? Lots of kids do dumb things. So what's the number? I'm just throwing this out as a general thing. Name 2 things that kids get on that they end up with a broken bone. Monkey bars. Trampoline, thank you. If you could roll in a third, what would it be? Bicycles or anything that has wheels on it. So I'd say that's probably the case. This thing, I was down there as a resident trying to get these x-rays. If you don't get the x-rays and you send somebody out of the ER or wherever it is and you don't get the right x-rays and they needed to be splinted or they needed something and you didn't get it, you're liable for that. It's just the way it is. So I don't know what Dr. Lessenbury does. He probably does the same thing I do. I look at him like, I need a lateral, a real lateral. I don't want this oblique looking, I don't know what this is. Oh, but the child's, yes, I know this. I've been there. We've got to give the child something to allow them to get this x-ray, because if we don't, again, we're liable for this sending it out. Now we can just splint everything and say, heck, we'll just look at it later, but that's not the right thing to do because they might need surgery right then and you can't tell. And I've got plenty of those. We're not going to go through them, unfortunately. But yeah, don't let that happen. Anything else that somebody saw that, telling somebody a surgeon a story, you'll lose them really fast. So if you start saying their name's this, that, or the other, and they were doing the Olympics and this or that or the other, they're either going to cut you off or they're going to start snoring. You don't know which one they're going to do. And then once you get back to something that's salient again, yeah, we're back online. So later on, we're going to kind of say what's important for us to hear because we're planning on doing surgery. I mean, that's what we do. So if you're going to talk to one of us, that's what we want. The flip side is you all want to know a lot more things that we can't provide, so don't even ask. Nobody laughed. Okay, well, that's right. You know what I'm talking about? Like anything, medicines, okay. All right. Right, that's coming. Blood thinners and I'll give you a list. All right, so it's important that we get a good history, right? We need to know their age, obviously their sex. With women, osteoporosis is common, although it's happening more often in men. So it's important to understand the mechanism. So when you call, you say exactly how they did it. So this right here, what do we typically call that when somebody falls like that? Yeah. What does that mean? All right. And that's a very common one. And then with the older folks there on the bottom right, that's usually a situation they tripped on something, they got going too fast, they stepped the wrong way. I mean, it happens so quickly to them, and then boom, they get a fracture that what you have to think is if I did that, you all in your 20s, 30s, that's not going to happen, right? That's how you got to think of that. So it's pathologic or fragility type fracture. All right, so it was an epic fail. He's doing it right. Okay. All right, so when you get the history, make sure that you're, not just checking in the one spot. So they fell, and I know everybody looks at this. So an elderly person falls and hits their head. You're all automatically going to get that CT of the head, right? That's coming because, it's an elderly. And then you might see something looks kind of funky. So you're like, okay, well, I got to x-ray that. But what you got to make sure you do is look up and down the whole body, which is the hardest thing to do because it takes time. So what you want to do, in a trauma setting, you want to go move that arm, move that arm, move that leg, move that leg. All right, if they move it around and it's fairly easy, probably okay, not 100%, but at least you've done something. If you don't move, if you look at just the thing that looks wrong and don't look at anything else, you're going to get in trouble. You're going to miss something, sure as anything. All right, so again, this bottom right, that's probably fractured, right? Bruising, that's pretty common. Can't really tell what's going on there. That could be tennis elbow as far as we know. Okay, a couple things. This is for you all again. Numbness or loss of movement. What would that be associated with? Potentially. There's more than one right answer. Nerve damage. So let's say this is all one person. They were in a car wreck. Here we go. Pain and swelling, numbness or loss of movement. What are you thinking? Car wreck. MVC. Go ahead, spit it. It's okay. What are we thinking? Well, I'll be worried they have a spinal cord injury. As soon as I see something like that, man, I'm freaking out. I'm the first one called down to the trauma center. I was the intern, and they made me do the anal wink. I mean, I had to stick my finger there every time they called me down there because you have to check for that. So anyway, skin pallor, cyanosis, blueness of a limb. What would you think there? Whole thing turned blue. Go ahead, spit it out. You guys aren't going to be wrong. Right, you've lost vascular supply somewhere, right? You could have a femur fracture and it lacerated the superficial femoral artery or something like that. But, if you're looking at everything else and then somebody over on the other side does not feel the other arm, but it's blue, you got to worry about that. All right, blood in the urine, what do you think? Lots of reasons, but it's in the urine, so what do you all think? Pelvic fractures for sure. Yeah, I'll tell you one of the bad ones that we used to. Again, we don't see them here, but you get those open book pelvis fractures, and it just splits them in half. So we used to get that because we had a lot of motorcyclists down in Jacksonville around Motor Week or Biker Week. That's what it was. It was a bad time to be there. Abdominal pain could be almost anything, so I won't stick you to that. Difficulty with breathing, MVC, rib fractures, pneumothorax. Okay, we won't do that. All right, so you're asking all these questions. That's basically what it is. And then what we're thinking is finally general medical history in preparation for anesthesia or operation. So here's what it comes down to us. So you call us up and you say, I got this little old lady. She fell, ground level fall, pretty common. Can't stand up. You got the proper films. You did a full body check, and you rolled her right leg, and she's like, she's dying, hurting up near the hips. You're like, okay, it's probably hip fracture, but not necessarily. Could be a pelvic fracture, could be something in the spine. So don't leave these things out. Examine everything. And then you're going to call us, and you're going to say, this is what this is, and what do you think we're going to ask you? Because we're preparing for surgery. That's okay. Yeah. All right. Allergies, yeah, we'll ask that. Because we're going to give an antibiotic, so that'll be on there. That'll be lowered on our list, believe it. Blood thinners. Blood thinners is always on the list. When's the last time they ate or drank? So I was on the list. All right. Have they had any previous surgeries? You wouldn't think that would be that important. You're like, well, if they fractured their hip, but they've had a inguinal hernia surgery before, and we're considering a certain pathway to get into that hip, it would be good to know that, oops, that pathway has been spent. Okay. You wouldn't necessarily think that was a big deal, but it is. What else? What else do you think we might ask you? Anything? Are they a smoker? Potentially. Are they diabetic? That matters to us. That matters to everybody. Do they have a heart history? Have they had a cabbage? Have they had stents? Do they need other people to see them before we can see them? Anyway, all that stuff matters, and that's the way you want to think. If you were going to be a surgeon, what would I want to know? And then just give it to us. If you come with that PEDS thing that they did, Lord knows we don't need to know all that stuff. Okay. All right, so you're going to, this draws you into this guy's wrist. Something happened because it has a cast on it, right? So that's the obvious thing, artery nerve damage. Look for associated injuries in the region. Look for other issues in other body parts, okay? So don't miss something like that. Guy's missing an arm. But he has a good sense of humor. Can y'all read that? If you're happy and you know it, clap your Okay, anyway. So good humor. All right, so first thing you're going to do, you're going to look at the patient, right? Kind of assess. You're going to feel. You got to touch. And then you're going to move things. It's fairly easy, right? All right, so you're looking for some kind of, sometimes it's easy. There's a deformity there. You everybody see it? All right, what x-rays do we need on that? What do you think? Well, first of all, what is that? Sometimes it's hard to tell. We'll say for the sake of argument, that's an elbow. It could be a knee. I'm seriously, it's hard to tell, but let's say it's an elbow. What x-rays do we need? Well, so if we could get them, that's not how it works, is it, Dr. Kaiser? We usually get, if we're lucky, we'll get the elbow, and then we might get a forearm. Sometimes we'll get a humerus. It's unusual to get a humerus. But we'll probably get the elbow and the forearm, or it might be an elbow, skip the forearm, go to the wrist. But we've got to have the elbow. Now, when we get the elbow, we got to have at least 2 views, so that's coming up. All right, some things are obvious. That's quite horrible. A lot of mangled extremities that I used to see. We don't see those here too often, I don't think. How often do you see those, Dr. Kaiser? Mangled, absolutely spaghetti wrist looking. And you send them right off pretty much. Just get them tanked up and send them off.
Honestly, a lot of times the EMS flag up before we do that.
Yeah. Oh, so they report it to you and you say, eh.
Yeah.
Okay.
And there's a, inverse proportionality of, they're able to fly a helicopter and more to do that. So,
Okay.
if it's raining out, we want
All right. Look for associated injuries, even if no complaints. They used to drive this home when I was a resident. You can have a big injury like in the pelvis, open book pelvis. You're going to be like, this other stuff doesn't matter. That's the thing that matters. But you still want to know, right? Here's an example. So, calcaneus fracture. We got a 28-year-old male, falls from a roof. It happens around here. Takes most of the impact to his foot, to his calcaneus, and he ends up with calcaneus fracture. Looks pretty nasty too, doesn't it? All right. So you get that x-ray, you're looking at it, you're going, okay, well, that's his problem. And then he says something else to you. He says he doesn't really report anything else other than there's some numbness in his other leg, and it's in his groin, and his leg feels a little bit weaker than normal to him. So then you go back and think, well, what would cause that? So think about the mechanism. So if your foot hits straight down like that, where does the energy go? It goes right up. So anything above that could take a hit. And it turns out this guy had that. Okay, so he had a compression fracture in his back, actually a burst fracture, and it was putting pressure towards the left, even though so these things are associated with each other, but it matters. Every extremity matters. If somebody falls 20, 30 feet off a roof, do you think the only thing they're going to do is fracture their calcaneus? I mean, if they're really lucky, or if they're Amish. I'm telling you, I've seen Amish fall off things and they don't get hurt. But, so when you're feeling for things, you're feeling for crepitus. What's crepitus? Rice Krispies. Crunching. Crepitus is crunchy. Rice Krispies. And that's exactly what it feels like. I know most of you haven't taken something's broken, it goes and it's flopping everywhere, and nor do you want to. But you may hear it, something's moving, you're like, oh, that doesn't sound right. All right, abnormal movements, check all four extremities, you're just checking everything, right? Even a little old lady that falls, you cannot not check the other extremities. You've got to check every extremity, even if their main complaint is I can't walk. I don't know how many times I've seen that they'll have a proximal humerus fracture. I'm sure Dr. Kaiser has too. Somebody's seen them, and then he goes back and he's like, wait a second, she's got shoulder pain too. Why aren't we looking at this? All right, rule of twos for x-rays. Here we go. We're rounding it up. All right, so you got to get two views. All right, so this is a single view, right? AP. Does anybody see anything on that? Tip fib. Anybody? Nothing. Well, maybe you do. Maybe you can see it. Maybe you can see that white line just a little bit. But as soon as you get the lateral, look at that. Okay, this is why we don't get a single view, and this is why we get a true view. So if it's AP lateral, it's got to be AP lateral. Okay, and I've harped on the radiology techs and everybody down there. If you get your views, get them right. All right, we won't get as much trouble if we actually can see what we're looking for. All right. All right, two limbs, PEDS, very commonly done from our ER, and they do well with it. So if somebody has one side the right side looks like this, left side looks like that, they obviously look different. That's helpful to you, right? Because these kids have physes and their ossification centers come at different years. So sometimes you're like, man, that looks like a void, like a black void in there. Well, it's not a void, it's cartilage, and it hasn't ossified yet. So it gets very confusing. But on this one, you can see on the right and then on the left, see how it's kind of come off? So it's a lateral condyle fracture. All right. And that's me pointing it out. Good job. All right.
So is that for every injury?
I would say to you that if you're not sure what you're looking at, you understand? So if you're examining a kid's elbow and you're pushing, and then you get that x-ray, and you're like, ah, crap, I forgot. I can't see any of these ossification centers. It's really hard for me to tell what's wrong with this. You might as well get the other one. So kids under 10, probably a good idea, especially around the elbow. Nothing wrong with doing that. All right, so we already talked about this. 2 injuries, right? So make sure that you don't leave out the x-rays on something else because you didn't check. 2 occasions, so this is a little bit different. So there's some fractures that are very commonly missed. And there's reasons for that because you can't see them the first time, most of the time. I would say to you, you can see that barely, but we're so used to looking at it. So this is your scaphoid, right? One of the most commonly missed fractures in the ER by nobody's fault because you barely can see it. Where's the pain on that? If somebody falls an outstretched hand, foosh, right? Where are they going to say that hurts? Snuff box. Good. Every time. So if you push in the snuff box and it hurts and that's normal, what are you going to do? Right then, what are you going to do? You don't have to be crazy and get a bunch of tests. You're going to splint that. You're going to say, well, I don't see anything, but this could be this, and we need to recheck this. And so in a couple weeks, boom, you got a fracture line that shows up because your body's resorbing the bone that's damaged. So it actually makes the fracture line appear. All right, you do not want to miss these because if you do, well, crap. I had another shot on there. If you miss those, you end up with non-unions of scaphoids, and they're very hard to deal with because the blood supply is very unique. You have blood supply coming to the proximal part, and then it kind of skips the middle part, comes back around to the distal part, and they meet in the middle. So you don't want to miss that. All right, 2 joints. Somebody said that earlier. All right. So forearm film, right? Is that a complete forearm film? What do you guys think? What's missing off that? Elbow. Elbow's missing. We don't know what happened over there. It looks pretty bad though because, you know, that's all the way apart. How in the world could that happen and not break that other bone? That seems kind of weird. Well, lo and behold, you check the joint, right? Above and below. We have a joint above and below. And you see the radial head is dislocated. So there's a special fracture. It's a Montasia fracture. We've got to fix it. Okay? All right, so just going through these again. Always 2 views. If you can remember anything, remember that. We get a lot of different views. We get APs, laterals, obliques, and all this stuff. Ankles are a little bit different, but if you can just remember 2 views, and when you see the x-ray in the office, if you're checking it, first of all, check it. Don't look at the radiology read first. Train your eyes to check the x-ray, and then compare what you think to what the radiologist said, and you'll learn something, right? Because they should know, and it's going to teach you something. But if you don't have the right views, you gotta know you don't have the right views. Okay? Because I'm going to expect if they come to the office to see me after you all have seen them, and they bring their disc in or whatever, and I look at it, I'm like, well, doggone it, we don't have a true lateral. They let them go without a true lateral. Okay? It's important. 2 limbs, peds, 2 joints. So if you have a midshaft of a bone, let's say it's a tib fib, you want to see the knee, you want to see the ankle, right? 2 injuries. Let's see, besides scaphoid, talar neck fractures are missed pretty frequently. Same reason as the scaphoid. So if you fall the wrong way and you have pain in the mid portion of that talus, it could be talar neck fracture or Liz Frank. That's another one that's missed frequently. 2 injuries, 2 occasions. Again, that's kind of what we're talking about. All right, office setting versus emergency room. We have all these splints everywhere, right? All right, so pet peeve of mine. Somebody has a L2 compression fracture. See it on x-ray. They leave wherever. They come to our office a week and a half later with nothing on. No brace, no nothing. What do you guys think about that? Anybody? Bueller? It's also the type, which we're not going to go through that, but if you have a burst fracture, that's more energy than just a compression fracture. There's more energy in the flexion distraction. There's all these different fractures, but you want to be safe. So what I'm telling you is this. You're never going to go wrong by putting somebody in a brace and then we take it off of them. You understand? Because you don't need to make that decision. But you are making a decision if you let them leave without having a brace on. Okay? All right. All right. Where's the fracture on this? Anybody? Look hard. Bueller. Anybody see a fracture in the radius? Nah. Ulna? Anywhere? I love residents. There's pain in the snuff box. Now what? Yes. So, easy to miss. Treat it. This is it. That's what happens if you miss these. You see that on the left? That is really hard to treat. Okay? You have to get a vascular graft. It's trouble. You can't put a screw through that because it's dead in the middle. All right. Of course, everybody's seen the splints. The only reason I'm even putting this on there is because when you apply a splint to a distal radius, radial styloid, whatever you're applying it to, you have to think about how you apply it and what's going to happen to that patient after you apply it. So if you put pressure in places when you apply it, those places will show up when we take it off. Skin breakdown, especially on elderly folks. So the general rule of thumb is that when you get to a bony prominence, pat it extra, right? Make sure there's not a crease on these splints that puts it right in a spot where it's going to cause extra breakdown. Because these older folks especially come back and they usually will have some kind of skin tear or something bad. Don't need it. All right. What kind of fracture is this? Looks bad, doesn't it? Kind of looks like they have a growth plate. You think it's a kid? Growth plate. We just have a lateral though, so we can't tell what kind of Salter Harris fracture this is. There's a couple different ways to describe this. If you're describing this to somebody, you go, okay, well, how far is it displaced? Or translation would be another word for displaced. So you say, oh, that's 80% off the top. Ice cream's off the cone, about 80%. And I would understand what you're saying. Or you can say how much apposition is left, which is much more confusing to me. So if you say, hey, there's 20% apposition, well, okay, that means it's 80% displaced. So it's easier to say how displaced it is. And that's how we figure out, don't touch that. Let's just take one stab at it because that growth plate has really been messed with. All right, on this one, there's an AP and lateral, so we can tell this is a Salter Harris too. But still don't mess with it. If it has a physis that's open, you don't want to take that on. All right, clavicle fracture, mid clavicle. Surgical or non-surgical? You're in the ER, guy's 28 years old, his wife's with him, they're wondering what they're going to do, and they ask you to say, do I need surgery for this? What do you say?
Yeah, let's call the surgeon and ask.
Oh, don't do that. What do you not say? I want you to really think this through. You're sitting there, you're looking at it, you're like, well, that looks pretty dang bad. Looks surgical to me. What have you set them up for? If you tell them that's surgical or non-surgical, what have you set them up for? An expectation. And then when it's not met, they're confused. So they come in the office, they're like, well, they said this was surgical. Well, shoot. Look at that. 12 weeks later. So if you don't, there's some bones that will heal together, some won't. It depends on so many factors. Don't put yourself in that position. Just say, I really don't know on this, but I know where I need to send you to find out. Okay? And just leave it at that. Don't give an answer that you can't back up. Yeah. Yeah. The skin is tenting, then you could say something, I guess. The bone sticking out of the skin, it's surgical. That's true, I didn't. Treatment for this, what do you think? Surgery? No surgery? Looks pretty well lined up. I'd hate to mess that up, so we can always make that look worse. So we just put them in the brace. And that's the end of that. All right, so what do you see on this x-ray? Well, I pointed it out. What do y'all see on this x-ray? Take a look at it. Basically kind of a chest x-ray, but not really. So the important thing to do is to get yourself a little pattern to look at everything that's in the view box. I don't care how you start. And this is not a great x-ray, but there's the other one.
That bothers me.
Yeah, so
I
that,
just thought it was the view. I thought
even though you can't quite see it, that's an AC joint dislocation, right? Separation. But look at the whole thing. All right, which hip has a fracture here? Right or left? Does the right have one too? Right or left? This is left, this is right. Which one has a fracture? You guys scared me there for a second. I'm like, both. All right, so that's our typical elderly osteoporotic, balls all the way off the tee on the right. This one is a type 1, we call it. A valgus impacted is another way to put it. So we have, of course, we don't have the lateral, so we can't say for sure, right? This is just an AP. But if it is truly lined up on the lateral as well, we have about 3 different options. Depends on what the patient's like, what they're, if they have dementia, there's no reason to put screws into a head of somebody that's demented that's not going to, in my mind, going to not follow your instructions. So I'll be like, whoop, I'm throwing a hemiarthroplasty in that because I know they'll weight bear the next day and it's not going to matter. But anyway, it's important that you notice if somebody can't put weight through something, keep looking. All right, I think I'm about, there we go. Any questions? Anything? Not anything about fractures? I know that's a lot to take in.